welcome everyone to one of a series of webinars that we have on ACEs and trauma-informed care. I'm Shirley Z. I'm a family doc and chair of the ACEs working group, and I would like to introduce Dr. Evelyn Voyager, a First Nations elder, who would do our land acknowledgement. By way of introduction, Dr. Evelyn Voyager is a retired RN who continues to travel far and wide to educate others about the First Nation way of being. Her goal is to improve understanding for her people by bringing that awareness to folks that will work with First Nations people. And her goal is to improve the health and outcome for her First Nations people. So over to you, Dr. Voyager.
I welcome you in my language. Welcome. That's what Kelakesla means. Welcome to the land of the Comox Nation. I'm not of this area. I come from the mainland, but I would have loved to tell you history of the Comox Nation. It's a very rich history, their beginning, their origin stories, which I believe we all should know, and because we would really appreciate the land that we're on if we did. So I welcome you onto their land, and I'm sure that they feel very honored that we are on their land, and hope that we have a good session. Hey, thank you.
Thank you very much, Dr. Voyager. So a number of us that is participating on this webinar were members of the ACEs working group and has been exposed to the Touchpoint training and continue to rave about it. So that piqued our curiosity. And we have a number of them on the panel today, family doctors, psychiatrists, nurses, occupational therapists, and parents that can attest to the benefit of this training in terms of the work with the patients, with their community, with their healthcare teams, for their own families, and for themselves. So I was very curious, and we have now the three founders of the only Canadian Center for Touchpoint Training, located, like Dr. Voyager spoke about, in beautiful Comox, BC. So we have Jan Forens, we have Vanessa Hitchcock, and Andrew McKenzie that will tell you what it is about and how it is going to improve everything about what we do. So over to the three of you, Jan, Andrew, and Vanessa.
Thanks, Shirley. So as a Touchpoint trainer, I'm just going to tell you a little bit about what Touchpoints actually is, because a lot of you are probably eager and hoping to understand that from this call. So Touchpoints is a developmental and relational model of practice for practitioners of all types to use with clients. It's based upon the work of the late T. Barry Brazelton, a famous pediatrician from the States. And the approach is built upon decades of Dr. Brazelton's distilled knowledge and research about early brain development. The ultimate aim of the model is to support parents' ability to be emotionally available to their children by supporting their understanding of their children and by supporting their relationship with their children. And so through Touchpoints training, you'll be joining a network of professionals working to change systems of care to be family-centered, focus on strengths, and to be trauma-informed as well. And so Touchpoints as a developmental framework is a bit of a different way of being able to view all development as occurring within the context of relationships. And this is one of the most underpinning parts of it. It's a way also of responding to this as providers through this model. It's based upon systems theory, being culturally responsive, and also being reflective in the way we practice. And so what is a touch point versus a milestone as far as development is concerned? A touch point is a predictable period of disorganization or regression in the development of a child as a child learns or acquires a new skill, and the milestone would be that skill that's being acquired. And in touch points, we look at development as happening in regressions, bursts, and pauses. And from different forces, such as internal forces, external forces, and the child's own central nervous system. So it's a very systemic and broad approach to looking at development. One of the most significant parts of this is how we're able to come alongside families during these periods of disorganization. And that's where the model really takes off in supporting practitioners and working with families. And one of the key ways we do this is through something called anticipatory guidance. And this is a way of helping clients foresee the potential regressions or disorganizations that happen in development and understand what may be preceding developmental bursts that their children are going through. So Vanessa is going to talk a little bit more about the relational framework of touch points and how aspects of this really support this kind of anticipatory guidance. So over to you, Vanessa.
Thanks, Andrew. So as Andrew previously mentioned, there are two key frameworks for touch points: the developmental framework, which Andrew previously explained, and the relational framework, which I'll now briefly speak about. So touch points relational framework is a way of thinking about building relationships very intentionally with the goal of supporting the family system or the parent-child relationship. The touch points way of understanding development is embedded in knowing that all development takes place within the context of relationships, and thus the touch points approach offers skills and strategies to help us as providers support these really important relationships. As touch points providers, we strive for collaboration, where the agenda of what happens during an interaction, an appointment, or a visit is a joint agenda, not a top-down teaching to caregivers. The relationship between the parent and the provider is a partnership. Touchpoints provides tools for us to use to be intentional in terms of building our relational practice with families and getting to know who they are and what their agendas may be. Such tools include a list of parent assumptions, provider assumptions, and guiding principles. The assumptions offer us an attitude or an anchor to intentionally choose to operate from. It's not a fact that parents need to prove to us. Using these assumptions as our attitude towards families supports us in being strengths-based, which is especially important as we consider some of our most challenging families. Ultimately, Touchpoints is asking us to make a paradigm shift from deficit to positive, so looking for what's right, strengths, what's working instead of what's wrong, the problem, or the deficits. Looking at development as multidimensional rather than linear, a switch between prescriptive to more collaborative, objective to empathetic, and strict to flexible. So Jan is now going to expand on what Andrew and I had said and give us a snapshot of how Touchpoints informs trauma-informed care and the uses of the ACEs questionnaire.
Thank you, Vanessa. I feel like we're on Hollywood Squares right now. I think just a little bit of context is probably what I'm hoping to provide. I have done probably about 10 years of training with Dr. Bruce Perry, which is a sort of a trauma-specific model looking at brain development and what happens in the development of the brain when you are experiencing toxic stress or adversity. And so the ACE movement, I think, is a legacy that comes out of the collaborative, the Child and Youth and Mental Health Collaborative that was supported by the Doctors of BC and really brought new light, I think, across the province, not only with community partnerships, but with physicians to really understand and start thinking about the impact of adversity on physical health. We know that trauma impacts emotional health, but I think the work of the collaborative, which of course still lives on in some communities, thankfully, this ACEs working group is sort of that, still that grassroots movement that is pushing this work forward. And I spent many, many days sitting in those big ballrooms, listening to people talk and get really excited about how can we practice differently? How can we take what we're learning through science and all these really like light bulb moments that people were having as they were learning more about the impact of adversity on health. And what struck me, because I had just taken touch points myself, I went to Boston and took touch points, and I kept thinking, we know that the understanding of the science is becoming more mainstream and more people can talk about it and understand it, and they look to their patients and they're like looking at them slightly like, not what's wrong with you, but what happened to you. And I think that that's amazing, but I think there's also this gap. If we're going to start talking to people about their adversity and their trauma, then we need a skill set, we need a way of being, and we need something to ground us in those absolutely difficult conversations that we want to have to know our patients and our clients and our families better. And so the kind of light bulb for me about 5 years ago was Touchpoints is that thing that's missing from trauma-informed practice. And fast forward to now, I think many physicians are using the ACE questionnaire in their practice, which is exciting if they feel confident in how they kind of respond. If someone tells them I have an ACE score of 9 out of 10, then what do you do? It's not just about referring people out. Someone has just shared a very intimate and powerful piece of information and possibly never have shared that before. And so you may not know which of those things happened to them and when, but you do know that they've been through a lot. So then what do you do about it? And I know from all of my lovely Touchpoints colleagues on this call today that Touchpoints has actually allowed them to really be anchored and grounded in certain principles or assumptions that they can make about strengths that the family or the patient has despite being through all that adversity. It gives a skill set and something to kind of help you actually be with people in a way that we all hope to feel when we go to an appointment. And so I think any appointment when you're going to a physician can be stressful, or going to talk about your mental health can be stressful for anybody. And so thinking about the best possible scenario, I think Touchpoints just gives that scaffolding and that grounding for people who are looking to have those difficult conversations. Sometimes you don't even need to ask, sometimes people just tell you, which also means that you're practicing in a lovely relational way. And so I think that that was a light bulb moment for me, and that's kind of how this movement started. And I think that the evidence that you'll hear tonight will give you more understanding of what Touchpoints is and why it's so important. I think when people started to understand the ACE study and subsequent studies that have proven the similar connection between physical health and emotional health and adversity, I think people felt like they couldn't not do something about it. And sometimes it's scary to embark on, people refer to as the Pandora's box of asking those questions. And I hope that this, tonight you'll hear how even if the Pandora's box is open, how do you work and be with people in a culturally safe, trauma-informed, humanistic way that they walk out feeling safe and better, but also that you walk out of your day feeling great. So I hope you enjoy it, and I'm so excited to have everybody here tonight.
Thank you. I'm Rob Lehman, a family doctor on the Sunshine Coast and one of the co-facilitators for this webinar with Shirley. I just want to thank Shirley and Evelyn for starting us off and introducing. And I want to thank Andrew and Vanessa and Jan for giving us that tantalizing kind of overview of what Touchpoints is. So now we want to move along to a panel presentation of people that have actually taken the Touchpoints training in various capacities and how that has affected what they do and their approach to people in general and the relationships that they have. So we're going to go through a series of speakers, as you'll see on the agenda, and they will speak, each person will speak from their own position, and we'll introduce them as they start. And then we're going to get a feel for what it's like for people that have gone through the training and are using this information going forward. So they're going to speak for up to 5 minutes each. And then there'll be no questions during that time, apart from maybe comments that they have back and forth with each other as the panel members. And then it will be open to questions at the end of the panel presentation. So Please save your questions and then ask them on the Q&A, and we'll respond to those questions, and that'll be kind of a really good context for having a larger discussion. So I'd like to reintroduce Dr. Evelyn Voyager again, who will speak to us firstly. Evelyn has had experience with Touchpoints training, and she's going to speak to how Touchpoints has had an impact on her and what her hope is for the future of healthcare in British Columbia based on this approach to dealing with other people and relationships. Thank you, Evelyn.
Thank you. Thank you. I was very touched and thrilled to be a part of the session that in Touchpoint, because it reminds me so much of my own cultural teachings, how our culture is very family oriented, family centered, and I know that it is missing in a lot of our lives because of the residential school, because of all that happened. But I was very thrilled and to see that it's going to come back because of this teachings, being the relationship building in any life is so important. And I know that is part of what is missing in the healthcare system, the relationship building with the clients and their patients. It's not there. And they look for what's wrong, but they don't look for, well, what can we fix? Well, how can we do this, So, and that a lot of the problems in First Nations is something happened. Picture yourself being in your own culture and it was taken away. Picture that. You were told it was wrong to do this and wrong that. I know that's what happened to a lot of the First Nations. But hopefully a lot of my people, the young ones, will come up and experience Touchpoint. And what impact, how it will impact racism. And hopefully it will help those people who work to fully understand what happened. Nobody is born bad, nobody, but they've been traumatized somehow. And that's what I could go on and on about what I've seen in my own people and what I've seen in other people, but it would take forever. So hopefully the Touchpoint will help people to understand. And it isn't about First Nations, it's about the worker themselves. I can sit here and teach you cultural safety, but you're not going to get it unless you start dealing with your own issues. I can stand here till I'm blue in the face saying, "This, you can do this, you do this." But they can learn, but it will be mechanical. It won't be very sincere, and they're not going to do a good job. Their job's not going to be productive. I know, I've been there, and I know that how I had to change my own attitude to fully understand, build strong relationship with my people. And that's what I'm hoping Touchpoint will do. And in doing that, my hope for the future of First Nations is that it's going to be where we were before contact. We were a healthy nations everywhere. We lived off the land and all this. We had such strong teachings that kept us balanced in life. And I'm hoping and praying that the people who take Touchpoint it will touch them that way so that they can help and understand everybody, you know. And another thing I want to say is my people didn't look at physical, mental, they were not separate. And I can tell you that too, it is not separate. We have to look at them holistically. And if I have time, I'll tell you a story of an elderly lady that I worked with who had a stroke, but I'm going to leave that for last. But that is my vision, and that's why I'm still working, so that I can teach people and help them to see themselves so they can work better with the whole world. Thank you.
Thank you, Evelyn.
Okay, next speaker is Dr. Colin Bullock, and he's going to talk about how touch points from a family doctor's perspective.
Thank you. So I went into the Touchpoint seminar looking to brush up on my developmental pediatrics and get more detail and skill with respect to my developmental visits. What I discovered was, I guess in family doctor terms, was a conference that was part pediatrics, part counseling and psychological information, a lot of communication skills with opportunities for role playing and immediate feedback. And on top of all that, basically a balanced group, or a support group, a really tremendous networking opportunity. And I can probably name every single one of the members of my my seminar, which is unusual for a medical conference. And so the reason I wanted to improve my developmental visits was I found that there was a lot of information that really was on the physician's agenda going into a visit. There was a huge checklist. There's the Rourke, and there's a number of red flags to rule out. And in a time pressured environment, sometimes I feel like that was, didn't lead to great patient-centered care. Didn't leave a lot of room for the parents and child's agenda, which turns out there's a rich amount of action happening developmentally at that point, and an equally rich amount of opportunity for making a positive impact as a provider, as well as also enhancing the relationship. Having done touch points on a day-to-day basis, I do find myself going back to my touch points materials and cueing myself before doing my developmental visits, because there's a lot of technique talked about in this course. There's a lot of also why to do things, but also how to do it. And that often is, the technique is essentially drawing upon your own emotions or intuition in the moment. And I think we'll talk about the touch point assumptions and guiding principles probably later in the program. So I feel like I can be a bit more patient-centered in my visits. I am more, my ears are open more towards the parent and child agenda as much as I can from a safety perspective. And also that there are times where you just have to put away the Rourke checklist and just close your mouth and listen, and respond to what you're hearing. There's a lot of overlap between this material and other elements of communication skills that we learn in family medicine. So, CBT type principles, Fife and Bathe techniques, etc. And it struck me going through this course that development doesn't stop at age 6, that we're all on an ongoing developmental journey throughout life. And while this program distills some really helpful low-hanging fruit in terms of moments for inquiry and curiosity in the under 6 crowd, I hope in the future that body of information will be expanded throughout the lifespan. So specifically, I mean, we talked about first steps, walking, kindergarten entry, etc. But then I think about puberty, leaving home, finding a job, finding a partner, then becoming a parent yourself, retirement, etc. As developmental stages. There is also this relational framework part, and I think in family medicine, we're all interested in that long-term physician-patient relationship and a reflective practice upon the impact of our interventions on our relationship and attempting to enhance that relationship, enhance rapport, and gain access to our patients' trust, and therefore enabling us to serve them better. I'll leave it there, and we'll wait for the questions and answers.
Thanks, Colin. You really highlight the importance of the relationship piece in family practice work. We're so socialized to becoming fixers, with evidence-informed fixers in our profession, but the key is really that connection and relationship piece that you brought out. So thank you so much for highlighting that.
And our next speaker is Jenny Niehoff. She's a clinical coordinator of public health nursing in Comox. And Jenny, I think you're going to talk about how that developmental framework, how does it support public health nursing? You were going to look at, you were talking about recognizing the provider assumptions, Colin. I think you were going to begin that discussion about provider assumptions. And how can we change practices as a network of interdisciplinary providers and build faith and trust in each other's strengths and skill sets? By the way, I didn't know really anything about touch points before this webinar. That's why I've been so fascinated to actually hear what people have to say. And it's just wonderful to hear how this is going and how it's affected all of you. So Jenny, thank you.
Well, thanks everyone. There's so much about the touch points that I have personally found helpful as a supervisor of public health nursing, and that the nurses and the support staff that we've trained have appreciated and found has advanced their practice. As we've heard, I'm to talk about the developmental framework. I also want to talk a little bit about one of the key principles that many of us who take the training take away, and maybe even you will take away and be able to put it into practice after just listening tonight. That's using the behavior of the child as our language. And I'll speak a little bit about the provider assumptions. So from a public health nursing context on from Island Health, for many years we have been looking to redesign our perinatal services offering with the goal of moving from that problem-oriented approach to care that focuses, like Shirley and others have said, on the deficits and ways to fix people, which we can't fix people. They need to fix themselves. I'm thinking of what Evelyn has shared with us. We need to think about ourselves before, as we go into interactions. We wanted to move to a strength-based and collaborative way of being that would use our relationship as our intervention. And we were fortunate to be gifted a New Chalmouth way of being, which is called the Mother's Story, which has lots of great concepts, many that we've even spoke of here already. But it didn't give us the how to be. And Colin, I think you spoke to that too, where the touch points has provided us with a a real tangible developmental guide for viewing development through a contextual relational lens, and really does provide that how to be, and help us translate what is going on for the child, the parent, the family together, and into meaningful action for and with the families. Vanessa spoke about the way that Touchpoints thinks of the development. We were practicing using ages and stages or milestones, like probably many of you are, and then learning about the developmental framework that instead with Touchpoints, we look at normalizing regressions in behavior that happens before or during bursts of development. So being able to look at regressions, the regressions we often see are around mood, often sleep, because we are talking about the under 6, feeding, toilet training. And so being able to normalize these behavior changes and regressions with parents has really helped the nurse to meet the family where they're at in the interactions. I was thinking I would share, kind of building on what Colin said about preparing, reflecting before going into interactions with families. The Touchpoints guide, it's called Touchpoints at a Glance, gives us the information that we need for each touch point. It talks about what the child can do at that stage, what the themes might be going on for that family at a certain age. Say we take the 12-month there that's coming in. We can think about what a 12-month-old can do, what might be going on for the family, and thinking about anticipatory guidance, because we may not see them again for a number of months. And so when the family comes in and we offer them space for them to share how things are going, and they share with us things like, you know, he's just not himself these days. Maybe he's a little more clingy, or waking through the night. Instead of going down the conversation or bringing to our forefront what might be going wrong, because that's what the family's thinking. Is there something I'm doing wrong? Or is there something wrong with my child? We can instead hear about the behavior changes and think about and inquire about what else is going on for that child at this developmental stage. Are we also seeing bursts in their motor development, their walking, their running maybe at 12 months old, or their language? We can also shift the conversation to the strength of what we're seeing in the parents. We can look at the attunement that they have to notice what's going, that there's been these changes, and also think about the responsiveness that they are demonstrating with their child. Yeah, so then one of the strategies that we use in order to acquire some information from the family about what is going on and what's important to them is engaging them using the language of their child, as the behavior of their child as our language. And as I said, I think this is one principle, one of 8 principles that Touchpoints offers us that we often grab onto. So statements like when the family comes into your office and the child is snuggling into the parent to find some reprieve and some comfort, stating that, look at how your child snuggles into you as they come into an unusual environment or with people that they don't know, or she's really looking around and curious about the environment that she's in, or lots of different examples. So you see the behaviors, and we use that as our language. And when we do that, we not only show our interest in the child and the parent-child relationship, but we can sit back then and listen to their response, and parents usually then will open up with what is going on for them, what their concerns are, and what meaning they're making of the behaviors that they're seeing. And we often end up, as Colin mentioned, we're so trained to go in with checklists, and we need to do assessments. But we too were trying to move away from having question after question to get our answers, and instead using a tool or a skill like using the behavior of the child as your language. Most parents want to talk about their children, so they often will give us a lot more than we're actually maybe would have got from just asking a lot of questions. I think I'm getting short on time, so I just want to make sure that I also mention about the provider assumptions, because Touchpoints training was probably the first training that we had ever taken part in that really paid attention to the providers and what we bring to our interactions. And so there are 6 provider assumptions that really do, as Robbie said, give us the opportunity to have attitudes that strengthen and support our community networks. The provider assumptions that often speak to us especially is that we need the support and respect of the kind that we're asking providers to give to parents. So when we have a community like ours in the Comox Valley that have hundreds of providers, not just medical providers, but childcare providers, anybody that works with young children can get value and have appreciated the Touchpoints training. When we take this training and we use these provider assumptions, well, one of the things that we get from the training when we train multidisciplinary providers is that we build relationships and we learn about the different roles that providers have in our community that we maybe didn't know about before. And we also then start to speak similar language and maybe go into care meetings, multidisciplinary meetings. Again, like I say, thinking about each other and what we're bringing, and that we have a little bit more respect for each other's disciplines.
Thank you, Jenny.
Great. We now pivot to Dr. Linda Ueda, who's a family physician that works with high-risk youth, and she's going to talk about the impact of Touchpoints training on her work with her team. And she's the one that came back from the Touchpoint training and got us all enthusiastic. She's a real champion. So over to you, Linda.
Thanks, Shirley. Yeah, I think I'm probably one of the biggest cheerleaders for Touchpoints right now in BC. So I heard about Touchpoints through the ACEs working group about 1.5 years ago when Sarah and Jan came and they gave a short talk. It was probably 5 or 10 minutes. And so my practice is currently working at the Forensic Psychiatric Hospital with adults. And I also work with youth, 13 to 25. And so I don't have a pediatric practice, but I can't even remember what it was that you guys said, but I knew that your program had something to do with helping people with trauma in their lives. And so that's the reason I reached out to them and I said, hey guys, would you be okay if I came over and took the training? And I did that last year in September. The other thing that I do for my practice is I do a lot of speaking in the schools. So I educate teachers and students and parents about anxiety and depression. And I educate them about trauma as well. And what I found over the last 5 years in doing that is people go, okay, that's great. I understand now what happens. Our physiology has changed. Now what? Now what do we do about that? Now that we know this information, what is the fix? How do we unravel all of this? And so touch points training, I truly believe, actually gives us the skills. And they give us the skills through self-reflection, but also practice. So you heard some of the other panelists say that there's lots of opportunity to do some role playing, get feedback, reflect on the things that we might not even know subconsciously we believe, and bring with us into the situation. One of the highlights for me when I was doing the program was we had an exercise where we actually grew a child. And so the child was in utero and they were in dyads. So you would have the child in utero and the mother, and then you would have the mother and a newborn, and then you'd have a mother and a toddler, and all the way up to the age of 6. And so we were in these dyads just speaking to one another about what it was like to be the child, and then what it was like to be the parent of the child. Mm-hmm. And after we did that for some time, we did a debrief. And in my session, we had antenatal nurses who were brought to tears because they said, I have worked for babies for the past X number of years. And they said, I have never taken the perspective of the child. And, you know, so what Dr. Voyager was saying, this takes us from a place of do this, say this, do that, to a place of this, I can feel this in my heart. I can experience what somebody else is experiencing, what they have experienced. And from that perspective, connect with them. And that's what I found so powerful about the touch points training. The other thing that I found really helpful for my practice is, like I said, I don't have a pediatric practice, but I am in a hospital-based setting. And what I've found is, you know, we learn about these assumptions that the parent assumptions that touch points brings. And as physicians, we're often placed in a position of leadership where we are, you know, maybe asked to teach people about trauma and trauma-informed practice and ways of being with our patients. And so I have used the touch points training to help my teams interact with our patients. And so it's been very easy for me to translate the things I learned in touch points when it comes to speaking with parents to leading my team and speaking with the frontline staff. It's a very easy transition. And I found that to be very, very helpful. And so big cheerleader. I think Touch Points is a wonderful program. Like I said, it gives us a framework on which to build our practice. And there's also follow-up that comes after the touch points training. They don't just leave you hanging. There's follow-up. We talk about things in our practice. So go team.
Thank you very much, Linda, of the impact of outlining what the impact of touch point training has on your work.
Thank you, Linda. And now we're going to move along to Dr. Jane Ryan. She's a recently graduated psychiatrist working in Victoria, right, Jane? And she's going to talk to us about the touch points training she did and how does that help you working with complex patient problems and using the assumptions for providers in that context. Thank you, Jane.
Rob. So what I wanted to speak about was so I did my training in touch points in February of 2020, so just recently this year, and kind of fortuitous timing with just before the COVID restrictions decided to roll out. And one of the principles that a number of people have already spoken about, but that keeps coming up, is this idea of valuing disorganization. And boy, does COVID or a pandemic throw disorganization, and especially for myself transitioning from being a resident to a staff now practicing as a child and adolescent psychiatrist. What I found from touch points was, we all talk about the art, you know, there's the learning and the science in medicine, and then there's the art. And there's these threads that we've heard already from the speakers that have come ahead from me. Vanessa at the beginning talked about how one of the main focuses of touch points is on relationship and the importance of relationship, and how there's this paradigm shift from negative to positive, looking for positives instead of focusing on negatives. And there's a paradigm shift from, instead of being very strict and rigid, to being flexible. And then Jan talked about this word how. And I thought that how was really what hit for me the importance in doing the touch points training, which is, I've had lots and lots of training around being conscious or being aware and trauma sensitive, and what doesn't always come after is the how, or the art of how you put that into practice. I think touch points gives a roadmap or scaffolding, and it's how to be in difficult moments and how to actually bring yourself back to focus on the relationships. The example I wanted to talk about, where I found that came to mind when I was preparing for this seminar, was when I'm working with complex patients and their family members, I'm also working with lots of other team members and various doctors who have seen the patients before me, various different multidisciplinary practitioners who are either involved still or involved in the past. There's all these moving pieces. And then sometimes I'll also meet families who are really at tertiary or higher levels of the system, of the medical system. And one family in particular I'd seen had, I think, more contacts with physicians than I could count, you know. Lots and lots of different ones. Lots of different child psychiatrists had seen them before me, and I was seeing them for one time. And the question came into my mind, how am I going to be any use? And it brings up an idea of futility, right? Like, how do I counter this? How do I deal with this idea of futility, of just being one more interaction? And there's a guiding principle from touch points, which is recognize what you bring to the interaction. And that one I really struggled with, because there's a sense of, right, like, who's me? Like, me as the doctor, or who am I that I'm bringing? And I think it really means, like, you as the human being. What are you bringing to the interaction as the human being? And with that guiding principle, I was able to step out of really that kind of Dr. Hat role of, here's the information I need to give to this parent, to really coming back to just ways of what needs to happen in the relationship right now. There's another guiding principle for the valuing disorganization, which I already mentioned about, but valuing vulnerability as an opportunity, and to focus on the parent-child relationship. And I found myself thinking about this interaction that I'd had with this parent of a youth who'd had more contacts with the mental health system than I could count. And as we started to talk about the parent-child relationship and what the parent had done, and I was just listening for what was different, what was positive, and just having that paradigm shift allowed us to have an interaction where I started to see hope. I started to see hope in the parent. And I didn't have to point out the negatives. Those had already been pointed out multitude of times by other providers, and by not pointing them out, the parent would mention them. But by highlighting the positives and looking for the positives, there was an ease in the experience, and both of us left it having a higher degree of hope. I think that's my 5 minutes, Rob.
Thank you so much, Jane. That taking it from that feeling of futility to recognizing if we feel that way, what must it be like for those people sitting across the room from us, and going from that point and saying, okay, what do we need now, rather than getting into the doctor fix-it role of just learning how to be with people that are feeling very badly as well. Thank you.
So now we transition to Dr. Sarah Sandwich and Dr. Teresa Wilson, both family doctors that do maternity practice, and they've been touchpoint trainers, and they can speak about the provider and the parent assumptions and how you deal with the interactions with your patients. Thank you.
Thanks, Shirley. Thanks, Rob. And thanks everybody who's gone before us for saying everything that needs to be said about the practice of touch points. I think you've articulated it so nicely that I think what I'd like to share is just a short story about what it feels like to practice touch points in day-to-day work. And for me, that word, that practice, the discipline of touch points also comes hand in hand with play, because the act of listening and the observation and the reflection that we're asked to do when we're working in this way really feels like improv to me. And it brings a sense of lightness and joy and play. So here's just a little story about a delivery and a patient that I cared for in my maternity practice that I feel highlights so many elements of how we work with touch points and what the impact can be for us and for our patients. I'd cared for a family throughout their pregnancy, and unexpectedly, the mom went into labor with their first child 2.5 weeks or so before the due date. And her partner was stuck way up at camp in the far northern reaches of British Columbia when she broke her waters. And so they were on a bit of a deadline where he was doing a planes, trains, and automobiles kind of frenetic rush to get himself, down from the middle of nowhere on a flight. And then he got to Vancouver at just in time to get a taxi. I think he hired a limo to zip him to the Duke Point Ferry Terminal. His friend met him on the other side and literally drove up the highway at about 180 kilometers an hour. And so I'm hearing about this from the family the next day, because I was not the physician on for their delivery. It was Dr. Teresa Wilson, who is, I'm in my maternity group. And so I'm coming in to see them in the morning and congratulate them on the arrival of their baby. And they start telling me this story about how he wasn't there and he was racing to get there and his friend was driving him up and he was on the phone with his wife. And he got to the North Island connector, which, if you know our area, is like 8 whole minutes away from the hospital when the baby was born. And so he blasted in and ran up the stairs and burst through the door. And this is them telling me the next day. I burst into the room and I said, "I'm here." And he looked at me. And our brand new 8-minute-old baby looked across the room to the sound of my voice. And they couldn't stop talking about how, I'd sung to him every day when he was in her belly, and he knew me even though I hadn't been there. And they were just weeping with the thrill of the recognition of their brand new baby to their dad. And so I was so moved to hear this that I couldn't wait to share it. And so I was talking to Teresa after, and I said, and then he burst through the door and the baby looked at him and she said, "Oh, I said that. I said, your baby just looked at you." And I went, aha, this was the touch points moment where, because she was present and watching and attuned and using the behavior of the baby as her language, she was able to notice and then narrate the baby's behavior that to them transformed this potentially devastating moment of he missed the birth of his first child into, my baby knows me already, even just minutes old. And all of this relationship that we've been building for these 9 months together is present and crystallized. They never mentioned Teresa's intervention at all. She was not part of the story that they were telling of their birth. And so that for me was just the most beautiful example of when we can be present for these moments, and wearing our touch points kind of superhero cape, we have an opportunity to maybe offer or bring something that can be transformative.
Yeah, and I think, you know, it seems like such simple things, but when you actually get the opportunity to learn and understand a little bit more about what's happening with a newborn and their capacity, which is part of what we get in touch points, and then get to learn about these guiding principles and assumptions that you've heard people talk about. So there's a list of both guiding principles and assumptions that when we talk about sort of the how, that's what those are in the relational part of things. So we have these things to fall back on. And so another thing that people talk about, that Dr. Brazelton spoke about, was that at each birth, there should be someone in the room simply to ooh and ah over the baby, to allow this family to fall in love. And so one of our favorite, as people have shared, one of our favorite ones that we use is using the behavior of the child as your language. And so in Touchpoints, you get the opportunity to learn more about what babies can do, and then also learn how when you can describe that to a family, it can actually potentially decrease their stress and increase their bonding with their child. And so we try to do that on purpose, and it's really exciting. I don't know if that dad would have noticed it, but it happened. That baby just heard his voice and turned right to him. And yeah, it's as simple as saying, oh my goodness, he's heard you and he's looking at you. And whether he would have noticed, you know, it's who knows, but that's kind of the exciting things that we get to do using Touchpoints. So it's a great story. And I really, again, want to echo what Evelyn said about how in medicine we tend to be trained to look for what's wrong, and how fortunate I feel to have had the opportunity to be heavily involved in Touchpoints, and how over time that allows me the opportunity to look for strengths and see them, and actually start to just see them, and notice them so genuinely, and stop having to try to look for strengths, but instead that's my initial thing that I see. And so one other quick story, again, you've heard people talk about sort of valuing passion and valuing disorganization. And so we might go into an interaction with those in our minds, and that might help. And what I find is that often reduces my stress. So again, we're thinking about how we might be feeling going in. So there's a family that I see often, and you can hear them sort of coming into the clinic because there's so much chaos and noise and lots going on, and lots of vulnerabilities there as well. And it always felt quite overwhelming to see them. And I would try to be, again, like Colin talked about in family medicine, we learn about being patient-centered and all of these things. And yet somehow it still feels hard to do that. But with these guiding principles, it made it feel so much more natural to be with this family and observe their strengths and see their passion for their children, and their disorganization as an opportunity. And after taking Touchpoints and applying it more and more, I noticed that family, after our interactions, which hadn't changed in length, would say to me, "Thank you for taking so much time with me. I really appreciate it." And I had not taken more time with them, but I had changed my approach in quite a subconscious way, really. It's sort of this funny thing. You're sort of doing the same thing, but you're sort of not. And that's what's pretty amazing about Touchpoints, is that you're doing what you're doing, but you're doing it better, and you are genuinely changing the way that you're seeing people. And so I really feel that this woman in particular really felt different in our interactions, and really felt like I was more present and seeing her strengths and taking more time. So thank you.
Thank you, Sarah and Teresa, for sharing those wonderful stories about how Touchpoint training has impacted the way you practice and how you do it. So thank you.
And you've taken us to all those oohs and ahs memories that we have. And that just takes me back to just watching a sleeping baby, you know, and that kind of, is it oxytocin? That surge of oxytocin that just brings that feeling of joy that you're referring to. Yeah. And on that note, our last speakers are Brendan and Tracy McCann. Brendan's an occupational therapist, and he did Touchpoints training, but they're also a family that experienced the effects of Touchpoints through their caregivers. And Brendan's going to speak to us from both perspectives, and they're also going to introduce Callie, who's sitting with them. So welcome, lovely to see you.
Thanks, Rob. Just being conscious of time, I will try to be short and sweet, but this is Callie, and she was born, I think, 20 days after I did Touchpoint training. So my first interaction with Touchpoints, I didn't know that it was happening. And we were very fortunate to receive our prenatal care from one of the physicians that is on this call with us. I won't name her, but I was going to. And in our first initial visit with her, I didn't understand what was going on. And I think we've had pretty good care with physicians in the past, but I actually stopped her in the middle of a sentence and I said, "You are amazing. I don't understand what's happening." And I think at that point, Trey might have been in tears, like happy tears, and she didn't know what was going on. And we left our initial visit with our physician going, that was a completely different experience that I have never experienced in my entire life. And I wanted to tell the world, I wanted to tell everyone about how amazing this doctor was and how, like, I just felt a very different level of care when you weren't sort of given 20 seconds to speak and then interrupted. It was a genuine interest and presence and attunement to us, and a presence that I had never experienced in a visit before. And we looked forward to going to our visits, and we were so excited about just the trust and the relationship that we'd built. And so again, at that point, I was told that I was going to be registered for Touchpoint training, and several other panelists on the call were like, "Oh yeah, we're getting you registered, you're doing it." As I was working at the Child Development Center at the time, and was fortunate to do the training as a service provider working at a Child Development Center. I am now working as in my own private practice and teaching actually the infant and toddler development course at the college. So Touchpoints is kind of a perfect approach for myself as a provider. And one other quick story regarding, I think something that really resonated when the group of us met on one of our initial calls was something that Linda had shared around fatigue and burnout and vicarious trauma. And I think something that Touchpoints has allowed me to do with the assumptions is to take away some of those sort of strong feelings that we are given about families and children who may be challenging and difficult families for professionals to connect with. And I have been working with quite a few families who I've been referred to for children in care and children who've been adopted. And I find that not having a lot of presumptions going into visits has allowed me to make those relationships and build trust and connection with people that kind of has been a resonating theme with all of us. It's just that level of connection and relationship that is really what fosters change. And people feeling heard and vulnerable with us. So yeah, it's been incredibly valuable. As a parent, it was the best. We couldn't, I think Tracy and I both feel so fortunate and so lucky. And as a service provider, as a professional, it's been incredibly valuable for me. And it's stuff with the reflection that we were able to do as a group afterwards. I felt like I was touch pointed, and I feel like I'm now able to touch point other people. And so, yeah, thank you for being here today. And thank you everyone I think all of us have really embodied this approach and want to tell everyone about it. So on that note, I know we're conscious of time, and I will wrap up there. So thank you, everyone. And it's your bedtime.
Your passion, enthusiasm, everybody's that has spoken just speaks volumes, and certainly makes me want to learn more. So we're going to go on with the question period now, and I'd like to begin that. Maybe if the panel members, Shirley, jump in when you want to. The panel members would like to just reflect, if they'd like, on anything they've heard any of the other members say. And while you're doing that, if we could just ask the audience if there are questions, to use the Q&A part that we're getting them to use for questions. And then we'll field questions as they come in, and you can direct them to the panel in general or specifically to one of the speakers that you wanted to hear more from. So panel, can I open it up to you just to begin that conversation?
I think I wanted to just, in case anybody's turned off from doing the training because they heard the words role play, it's it's a slow build. And the other term we like to use in Touchpoints is perspective taking. And we did hear a lot about that we're really challenged in this training to spend time taking the perspectives of different people involved in the interactions. So don't be put off by the idea of role playing. By the time the really big role plays happen, you'll feel completely prepared and very well supported.
Thanks for that. Yeah, oftentimes in our teaching, when we introduce the concept of role play, people just groan. So thanks for prepping us.
You know, when we look back at your opening, Evelyn, and the words that you spoke, now it makes sense to me what you were referring to from that cultural perspective of feeling like maybe this is a way of getting back to those values that were embraced by your culture. And we've had a request from one of the audience members just to hear more about your perspective on your culture and how this applies to your culture and our culture.
Yeah. Well, I'm going to start out with Sarah and Teresa's story. That just touched me so much, because when a woman becomes pregnant, her husband is very much involved. Everything they do, like my ancestors truly believe the baby can hear everything right from the beginning. So the pregnant woman and her husband were not allowed to hear anything negative. We're not allowed to do anything negative, because everything that the couple did affected the baby. Everything. And this was to ensure the child was going to be well and balanced in life. That's why it was so important. And when the young girl had her first period, we honored and uplifted her too, and she was educated by the wise women of her tribe, for she was going to be the mother of tomorrow's children. From the very beginning, I believe our teaching was there right from the beginning. Like I said, when the baby's in there, you had to be so careful of what you did and what you ate, you know. So our and yesterday I was doing that for the students, nursing students. I was there for 2 hours teaching them all, the beginning of life to the very end, because death is even a part of our teaching. So I really enjoyed your story. Yeah, thank you. Did they want any more, or is that?
hopefully, Evelyn, you can intercept with the wisdom of your people throughout the question and answer period as the questions come up. There is a question specifically, there's a number of questions about people wanting to take the course, and that will be outlined at the end of this webinar, the opportunity to take it online during time of COVID. But there is a question right now about the comment on valuing passion and disorganization. What does that exactly mean? So open to anybody that wants to jump in and answer that. I think, Andrew, you introduced that concept.
Sure, thanks, Shirley. Yeah, those are two different concepts and touch points: valuing passion wherever you find it, and looking at disorganization as a way to come alongside the family. And so the idea of valuing passion is that, you know, in hearing some of the stories that that Sarah or Teresa were sharing about maybe some clients that are maybe viewed from other perspectives as being challenging, or maybe finding them challenging yourself, is trying to look at what you're bringing and shift your perspective a little bit to look at things about that family that may be looking at the passion that they have for their children, or for their role as parents, instead of looking through a lens of the challenges they're going through. Like, for example, thinking of, you know, a parent that might be at a meeting with people around school with their children, and, you know, maybe getting a little bit frustrated or seeming like they're becoming irate over trying to advocate for their child, but maybe shifting perspective instead of, oh, wow, this is such a difficult meeting we're having. And I'm saying this because I've spent a lot of time in my life working in the school system, looking at it from the perspective of, wow, this parent deeply cares about their child's education and their future and their development. And so it's basically two sides of one coin, and choosing to look at one of them from this perspective, if that makes sense. And you can imagine that from, you know, a medical or general practitioner perspective. And the other question was, oh, it scrolled up here. So that was value passion wherever you find it. And the other one was valuing disorganization and vulnerability as opportunities. And that's really about the essence of touch points. Touch points are those developmental disorganizational periods when kids are about to make a leap to another developmental ability. And so those can be disorganizing for families. How do we help the family? How do we come alongside to kind of make meaning with them and see what the meaning they're making in these situations is out of this disorganization? So instead of looking at it as a concern necessarily, or something that's negative, looking at it as a place to come alongside them in that disorganization, to kind of understand and co-create meaning with them. And I hope that makes sense. It's a really fascinating 3-day training, and these concepts really become more and more clear. As I was just talking about co-creating meaning, you will co-create the meaning with the cohort of people you go through the touch points training in, as you'll be in a relationship with all of them. So it's kind of part of the process.
Can I respond to the finding valuing passion? Just a case came into my mind. So as a practical example, you go into see a newborn baby after it's been born the next day as their family doctor or something, and you get into the room and the parents immediately start fighting. Dad is concerned that the baby isn't breastfeeding properly and wants the baby to be fed. Mom's exhausted and is also struggling with breastfeeding, and her body hurts. As a practitioner, there's a number of potential responses open to you. And I think these mantras almost, when you got them in your mind, or at least when you're not sure what to do, you can fall back on them. And it kind of, as Teresa mentioned, calms you down and allows you to seek a way forward. So valuing passion, you can say, look how much your husband cares about the health of his baby. And you can turn to the husband and say, look how much your wife cares, and just because she's now a mom doesn't mean she's immune from sleep deprivation and her exhaustion. It's a way of reframing the situation that brings everyone aligned to the ultimate goal, that we all share the same goal, that we want this baby to be healthy and we love this baby. There's so many examples of how these principles and assumptions really dovetail with a lot of CBT type principles, such as reframing. So that example popped into my head.
Thank you so much.
Thank you, Colin. I can see that we're not going to be able to get to all of these questions. So what I think we need to do is just say to people that if we can't answer your question this evening, that we will look at your questions after the webinar and try to respond to you personally with an answer. That fair to say? How will this model and approach work with the provincial move towards primary care networks, PCNs, and allied health providers being part of a team in providing care?
Can I share a quick response to that? And it's more just to link to what others have mentioned about the interdisciplinary nature of this training and how valuable it is to spend time taking perspectives from one another's work, but also just marveling at the strengths and capacities. So one of the provider assumptions is all providers have strengths and all providers want to do well. And by spending this 3-day training together, really understanding where we're coming from in the roles that we serve had this incredible effect on us.
Oh, a little bit frozen.
You froze, Sarah.
Yeah.
Can anybody complete her sentence?
And an OT that I know, and a wonderful
Mm.
That's the internet.
Yeah, you can't hear clearly sometimes.
Oh, I mean,
Breaking up.
but she described it as you're like a.
It's telling us to quit.
Yeah.
I think
as they are growing and developing.
Yeah,
Sarah, you cut out a few times there, so
Yeah.
we couldn't actually hear all that you were saying. But
We're going to
we
have
should-
to value this disorganization right now.
Shall
another,
we?
yeah,
shall we-
I think Sarah, the bits and pieces I hear. Oh, and she wrote in the chat session that it weaves us together in terms of a team-based approach. That this training does help. So another question is, how do we embed this training into formal educational system? Have we approached the Ministry of Education or Faculty of Medicine? Jan, over to you.
Oh my gosh, the dream lives on. You know, one of the groups that did the trainer facilitation in Boston with our group did work at a university, and I think in Milwaukee maybe, and that was their goal, was to create a training team that would actually be embedded in the university. Yeah, I mean, we have not approached the faculty because we all have full-time jobs alongside with Touchpoints. This is part of what we all do, but you know, we're thinking of Canadian domination to make everybody in this country. And I know that Andrew and Vanessa and now Brendan have done work at the college here locally, and I know that we've talked about that as a possibility, as a place to start. Because wouldn't it be amazing if people could start their practice with Touchpoints as their way of starting their career? So yeah, I love the idea, and if anybody has any powerful contacts, you just let me know and I'll take it from there.
So we had tried to get it onto a provincial training program, but at the time they were a little bit resistant because this is an American program. However, with the online approach now and with the Canadian Centre offering the online, we're gonna spread this information out. And as a community and Comox, you know, it sounds like everybody in the community has drank the Kool-Aid, and it's a great community to support. You know, child development and growth is really a community, a whole community approach. And there's something magical in Comox. I keep hearing about Comox Valley and what you do there. So, and now you have Linda and Jane that spread beyond the island, and there'll be more online training. So I think it will spread, Jan. And thanks for that aspirational goal.
In recognition that we're 5 minutes over, I just really want to thank all of you for what I found a very inspiring presentation. As I said, I didn't know much about Touchpoints before the webinar, but I certainly do want to take the course, and we're going to talk about that in a minute. When we started learning about ACEs and the pervasiveness of childhood trauma and adversity and how that affects all of us going forward, and you know, 65% of people have had at least one adversity on that 10-item scale, we started to get really gung-ho about, well, we should do ACEs on everybody. But then we recognized that to just do ACEs questionnaires in the absence of a trauma-aware, trauma-informed, culturally sensitive way was probably not a good idea. And that took us to recognizing, as we usually do, how the vital nature of relationship is the biggest gift that we offer as care providers. This takes me back to my residency training 40 years ago, where I learned whole person medicine at the University of Western Ontario, and I've been looking for you people ever since. And here you are at the end of my career, and it's such a treat to hear what you're saying. And even though I'm near the end of my career, I still want to learn more, and I want to take that training. So on to the training. Paula, were you going to put up that slide about resources in the training? Just to let you know that the beauty here is that this wonderful group of people in Comox are the first training center for Canada, and it's not going to be in person now with the pandemic still happening, but there's going to be virtual training that's going to be starting hopefully in January, February, from what I'm hearing. It'll be 8 weeks long and approximately 3 to 4 hours per week. And that'll be a combination of individual learning and live Zoom sessions. They're going to create a poll of the registrants to see what weekday, what time in the day would work best for people. And there'll be a post-training period as well, where there'll be a group reflective Zoom calls once per month for 6 months. So interested people, we're going to ask you to write to Paula, and we will put your information up. Paula, is that correct? Okay. And there will be a cost because of the cost of doing this, and it's going to be $500 per participant. So just really want to put that message out, because there was a lot of questions early on in the question period about how can we learn more, and that's how we can learn more. So if you are interested, those are the next steps.
Thank you.
And just to say, if you had to go to Boston to take this training, it'll be over $2,000 US. So this is a real gift from our Canadian Centre to us to be trained in this. And you are supported after the training, as a lot of the panelists has alluded to, in ongoing connection and support. So we'll be sending this information out post-seminar along with some resources to all the participants. And then you can sign up for the training if you're interested.
And we will try to answer the questions that we didn't get to during the webinar itself. So thank you so much, everyone, for a very enjoyable presentation. Thank you.
Thank you.